Good evening, everyone. My name is Rich Riley. I'm a proud member of University Hospital's Marketing and Communications team, and I'll be the moderator for our virtual health talk this evening. I would also like to acknowledge my colleague, Kelly Crow, who's played an integral part in planning and hosting this event as well. On behalf of the entire University Hospitals family, thank you for joining us for this evening's presentation, Time is Brain, Stroke Treatment. A few housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in the presentation, please submit your question through the Q&A feature, and our presenter will address questions at the end of her presentation. Also, this evening's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on the University Hospital's website, and as an attendee of today's session, you'll receive an email with a link contained within it to our presentation this evening. It is now my pleasure to introduce our speaker. Dr. Amanda Opaskar is a vascular neurologist at University Hospital St. John Medical Center in Westlake, Ohio, where she serves as the director of the Primary Stroke Center. As a Cleveland native, her mission is to deliver high-quality stroke and neurological care to the west side of Cleveland. She is also a clinical assistant professor at Case Western Reserve School of Medicine, where she shares her passion for neurology by developing and teaching the neurology curriculum in the graduate medical education program at UH St. John Medical Center. She also serves as a faculty member of the Stroke Fellowship Program at UH Cleveland Main Campus, providing clinical education to future vascular neurologists. Dr. Opaskar completed her undergraduate and medical school education at the University of Michigan in Ann Arbor. She received her Bachelor's of Science degree in Chemical Engineering, summa cum laude, with a minor in music. She then stayed in Ann Arbor to complete her medical degree. During her time as a medical student, she served on the student council as class representative and worked on projects such as reducing medical student mistreatment and enhancing curriculum development. She graduated with a distinction in education and also completed the Path of Excellence in Global Health and Disparities. Dr. Opaskar moved to Rochester, New York, where she completed her neurology residency training at the University of Rochester Strong Memorial Hospital, where she served as chief neurology resident. During her residency, she developed a passion for quality improvement and worked on multidisciplinary teams to develop innovative ways to provide efficient, high-quality acute stroke management. She then chose to return to her hometown to complete her fellowship in vascular neurology at University Hospital's Cleveland Medical Center. Ladies and gentlemen, I'm pleased to introduce to you Dr. Amanda Opaskar.
All right, thank you, Rich, for that lovely introduction. I'm very excited to join everybody tonight to talk about one of my favorite topics, which is time is brain, acute stroke treatment. Tonight, I would like to review some of the basics of recognizing a stroke and what you can do when somebody is having a stroke and what the treatment options are when you present to the hospital. So first off, I wanted to review what is a stroke. So a stroke refers to a brain injury that occurs when there's a blood vessel that is blocked and blood flow cannot get to the brain. And so the brain is then damaged by lack of oxygen and nutrients. But it also refers to when a blood vessel ruptures, there's bleeding within the brain. And so we actually have three different types of strokes. The most common type of stroke is called an ischemic stroke. An ischemic stroke is where there's a blood clot that blocks an artery, and therefore there's no oxygen or nutrients to that area. That area of the brain is then damaged and will scar. This type of stroke is usually due to atherosclerotic disease like cholesterol plaque and other vascular risk factors, and also from heart disease such as atrial fibrillation that causes blood clots from the heart to then travel to the brain. The next most common type of stroke is called an intracerebral hemorrhage. This is where there is bleeding within the brain. This occurs in about 10 to 15% of all strokes and can be due to two main causes: high blood pressure, and also a condition called amyloid angiopathy. This is a condition where there's a protein that builds up in the blood vessel and weakens the walls, making it prone to bleeding. The most rare form of stroke, but very serious, is a subarachnoid hemorrhage. This is only occurs in about 5 to 10% of patients. But this is where there's a brain aneurysm that ruptures, and the blood then goes into the surrounding lining of the brain, as seen in this picture. So just to review, we have ischemic strokes, intracerebral hemorrhage, and subarachnoid hemorrhage. And these are all referred to as a stroke. So next I want to talk about how can you recognize if someone is having a stroke. The American Heart and American Stroke Association has this very helpful mnemonic that summarizes how you can recognize a stroke. And this is called B FAST. The B in B FAST stands for sudden onset balance problems, where patients are having difficulty standing or walking. Then the E is for eyes, which means sudden onset double vision or loss of vision. And the FAST part stands for facial droop, where if you ask a patient to smile, their smile may be crooked and one side of it is weaker than the other. The A stands for arm weakness. If you have the patient hold up their arms, or the person hold up their arms, one of the arms might drift down. Then the S is for speech changes. The speech changes are either difficulty thinking of the words to say or being able to get the speech out, difficulty understanding what people are saying, or slurring of the speech, where it's difficult to understand what the patient is saying. And once all of these symptoms are recognized, the most important thing is to call 911 and go to the nearest emergency department as fast as possible. So just to review, the stroke warning signs are called B FAST. Balance, eyes, and then facial droop, arm weakness, speech changes, time to call 911. Now I want to go through why is stroke an emergency? And stroke is an emergency because the time is brain. And that's kind of what I talked about in the initial part of this talk. But time is brain because we have a limited amount of time in order to reverse the damage of the lack of oxygen and nutrients to that area. We have life-saving treatments like a medication called IV-TPA that I will talk about in a few minutes. And in rare cases, we have surgical procedures where the blood clot can be removed. But these have to be given within a few hours of the stroke symptoms starting in order to work. Next, I wanted to go through a little bit about what the EMS initial triage process is for recognizing and triaging stroke. Once you've called 911, the ambulance and the paramedics will come and do an initial assessment of the patient to determine if they are stable. But then they will do a standardized pre-hospital stroke assessment. This helps recognize if a patient is having a large stroke so that the EMS can then notify the local hospital that we're coming and the doctor and nursing team can be prepared. They can then triage the patient to the most appropriate regional stroke hospital. Additionally, the paramedics on the route to the hospital can check a patient's blood pressure. They can do a finger stick glucometer to check the blood sugar. And they may also have time to start an IV. This helps start the process of evaluation and treatment for patients and can help with the efficiency in recognizing strokes so that patients can get the more timely treatment. Once a patient arrives to the emergency department, there's a coordinated effort by the emergency department team to gather important history, do an initial examination, and start obtaining diagnostic testing. These are the three most important components of the initial history that can be provided that provide information about how we can help the patient. The first is the last known well. This is very important. This is how we determine a patient's eligibility for stroke treatment, including IV TPA and mechanical thrombectomy. Last known well refers to the last time the patient was seen talking and moving normally. It is different from the time of onset of the stroke symptoms, because sometimes patients will be last known well before they go to bed and then wake up the next morning and notice the symptoms. In that case, their last known well is the time that they went to bed the night before. This is important because as the stroke starts to affect the brain and cause damage, we have the IV TPA and treatments that we have are no longer, we're no longer able to offer them because of the risks of bleeding and other complications that can happen. The next most important piece of history that we need to gather is about the patient's medical history. And this includes a focused history on the relevant vascular risk factors, such as if the patient has high blood pressure, high cholesterol, heart disease, diabetes, or a prior stroke. And lastly, we need to know about the patient's medications. Really relevant in the initial history is whether or not a patient is taking a blood thinner, such as aspirin, Plavix, warfarin, or Xarelto. Next, the doctors are going to perform a very specific examination to determine the severity of the stroke. This exam is called an NIH stroke scale, which is a standardized stroke assessment that is done across the country. This stroke assessment determines the level of consciousness, any vision, speech, motor, or coordination difficulties. And it's graded on a scale from 0 to 42, with a lower number meaning more no stroke or mild symptoms, and a higher number can indicate a more severe stroke. Next, patients will go emergently to get a CAT scan of the brain. And so I wanted to show you a picture of a CAT scan of a brain. This is a normal CT scan, and we're able to get this study very quickly when patients come into the emergency department. This is helpful as it is quick and cost-effective way for us to be able to see if a patient is having a hemorrhage or an ischemic stroke. An ischemic stroke actually does not show up on a CT scan within the first 6 hours. And so oftentimes an ischemic stroke, the CT scan is normal when the patients come in. If the patient is having a severe stroke based on that NIH stroke assessment, we might also be able to get a second study, which is called a CT angiogram. This is a specialized CAT scan that uses contrast dye to look at the blood vessels in the head and neck. And I've shown you a depiction of what a CT angiogram shows. This is the two pipes that supply the front of the brain with the carotid arteries, and the two pipes that supply the back of the brain with the vertebral into the basilar arteries. And this is a normal CT angiogram. Next, we will evaluate the patients for the treatments that are available for stroke in the emergency department. The most important distinction is whether or not a patient is having an ischemic stroke or a hemorrhagic stroke, as the treatments are very different. For an ischemic stroke, we're aiming to break up the clot or remove the clot to allow for blood flow back to that area of the brain. And the two treatments we have are a medication that's an IV infusion called IV TPA. And we also have a surgical procedure called a mechanical thrombectomy that is similar to a catheter angiogram you would do for heart attacks. For hemorrhagic strokes, the treatment is very different. The goal is to rapidly control the blood pressure, reverse any blood thinners the patient might be taking, and obtain emergent neurosurgical consultation to see if the patient needs a surgery to try and remove the blood or relieve the pressure on the brain. Just to give you a context of these CAT scans, here in the ischemic stroke, you have the normal CAT scan. And then here you actually see a depiction of an old stroke. So as a stroke scars in the brain, it will create this hole that is black months to years after the stroke happens. In contrast, we can tell the difference from a hemorrhagic stroke as the blood will look bright white on a CAT scan. Now I'm going to focus on the treatment options for the ischemic strokes. I wanted to start with going through what is IV TPA. IV TPA is a clot-busting medication that is administered through an IV infusion over 1 hour. So patients will have 2 intravenous lines placed in their arms, and they will receive this infusion over the hour with the goal of trying to help break up the clot to restore blood flow to that part of the brain. Now, TPA does not always work by completely restoring the blood flow, but when we've studied it in clinical trials, we know that it does improve quality of life outcomes or stroke recovery in the first 3 months after having a stroke. This medicine has been available since the mid-1990s, and we've learned, and we still use it today, and it is an effective stroke treatment for all ischemic strokes, except these patients have to present with specifically stroke symptoms. They have to have a CT scan that is negative for bleeding. And that's very important because this is a clot-busting medication that carries risks of bleeding. We need to make sure that the patient's blood sugar has been checked, because actually very low and very high blood sugars can mimic strokes. And when treated, often the stroke symptoms resolve and it's not because of a blood clot. We also need to make sure that the patient is within 3 to 4.5 hours from the last known well that I discussed earlier. This is because as the stroke sets in and the damage to the brain happens, the brain becomes friable and is at a high risk of having bleeding in the brain because of the ischemic stroke. And so once the stroke has set in, the risks of giving IV TPA are too high. And so we can only give it early in the presentation. Now, who can benefit from TPA? It's not a perfect medicine. Not everyone is going to improve from getting TPA, but it can improve in many patients. This is a graphic depiction of 2 of the major clinical trials where TPA was approved. The first one is from the NINDS trial that occurred in the early 1990s. And this was when patients were given TPA within 3 hours of their last known well. And what we see here is of 100 patients that present with stroke-like symptoms to an emergency department, those that are in dark forest green are able to improve or recover to be able to live independently. Those that are in the lime green have some improvements in their stroke recovery. The patients in the white have no change. They do not get better, but they also don't get worse. And there is some risk to getting the TPA, with a 6% risk of life-threatening bleeding and a 3% risk of death. And that is depicted in these light red and dark red papers. In the 3 to 4.5 hour window, we call this the extended window. There's a slightly higher risk of bleeding and a fewer patients that will benefit because it's been longer since their stroke started. But we do know that patients still have the opportunity to improve. And you can see here the forest green is still significant and the lime green, but less than if we can treat the patients earlier. Now, I want to move on and discuss the surgical treatments for stroke. The surgical treatment for an acute stroke, which is an early presentation, is something called a mechanical thrombectomy. This is a catheter-based intervention, very similar to a coronary catheterization that you would do for a heart attack. But instead, the catheters are put in through the femoral artery in the groin, and they're snaked up into the neck and then up into the brain. We use something called a stent retriever, and that means that the interventionalist will bypass the clot with a, be able to go past the clot, deploy a stent, capture the clot, and then remove the stent and the clot all at once. We have learned that in the brain, the blood vessels are more friable than they are in the heart. And so you can't keep the stent in the brain. It just doesn't work that way. So it's important that the stents are retrieved with the blood clot. And then the blood flow is restored to that part of the brain. Now, the blood vessels in the brain are actually very small. And so we can only go to the largest vessels in the kind of early part of the brain, or the easiest to reach part, in the neck and in the early part of the head. As the blood vessels branch out and get smaller, we cannot reach catheters up into that area of the brain to retrieve the clot. So unfortunately, this surgical procedure is only used in large, severe strokes with blood clots that are in the big vessels in the neck or right in the early part of the brain. Now let's talk about who can benefit from the thrombectomy, and this is where we see a significant difference to IV-TPA. So remember, we're talking about very severe stroke presentations, and being able to remove that blood clot results in a significant recovery from the stroke. And you can see that in these very similar graphs to the IV-TPA. So this shows IV-TPA alone, which is on the left, versus those who were able to get both IV-TPA, or these are patients who were able to get the thrombectomy, and they were not eligible for IV-TPA. And we actually can do this surgical procedure up to 24 hours from the last known well. So patients may have had a severe disabling stroke with a blood clot and they were not able to get TPA, but they might be able to get the mechanical thrombectomy. And we have been very excited about this surgical procedure. It has only been available with positive clinical trials for less than 10 years. And it has really had a significant benefit on our patients. Now I want to move on to talk a little bit about the University Hospital stroke system of care. We have worked on developing a large network of stroke-ready hospitals and primary stroke centers across Northeast Ohio so that patients can have access to high-quality stroke care throughout the region. And this is a map depiction of all of the stroke facilities that we have, with the stars being stroke access facilities, the rectangles that are yellow being primary stroke centers, and then our red rectangle in the center is the Comprehensive Stroke Center at Cleveland Main Campus. There are different designations for which each of these hospitals can do, but every one of these facilities can recognize and triage stroke and initiate stroke treatment. And they can all communicate with the primary centers and the comprehensive center to transfer patients to the most appropriate facility. Our stroke-ready hospitals and freestanding emergency departments are able to do an emergency evaluation of suspected stroke patients. They have CT scanners to do the initial CAT scan, and they can start IV TPA in appropriate patients. Our 9 primary stroke centers are hospitals that have designated acute stroke teams, a stroke inpatient unit with written care protocols and stroke education pathways. They can also start IV TPA and admit those patients to the hospital for further care. And they also do additional outcomes and quality improvement projects and educational programs regarding stroke. Our comprehensive center at Cleveland Main Campus has a full range of neurological, neurosurgical, endovascular, and ICU care, and provides extensive services for our most complicated cases. If you're interested in learning more, I encourage you to go to www.uhhospitals.org and click on Healthy at UH. That concludes my portion of the talk. At this time, I'll take any questions that you have through the Q&A box. And if you're interested in making an appointment to see me, just to remind everyone, I am a neurologist and a stroke specialist. My clinic is at St. John's Medical Center in Westlake. So you can call 440-772-0050. We also have neurologists and stroke neurologists throughout Northeast Ohio. So if you're looking for an appointment closer to home, we have another number that you can call. And if you need any additional information on stroke, you can visit our website, uhhospitals.org/stroke. All right.
Great, thank you. We do have a few questions. So the first question is a question about brain aneurysm. Is this something a person is born with and it finally ruptures when the person is older, say in their 40s or later?
So some people are born with aneurysms, but more often they develop throughout a person's life. Sometimes there's a small number of aneurysms that run in families and are genetic, but we actually see aneurysms develop more in patients who smoke tobacco, and that's kind of really the big situation.
Great. The next question is, what is the full form of TPA?
Tissue plasminogen activator. That is what it stands for.
Okay, great. To everyone that's attending, if you have any more questions, feel free to submit them. We do have some time. I do want to remind everyone that May of 2021 is Stroke Awareness Month, and we will be having a couple webinars that month. Again, probably a webinar similar to what you were able to view tonight, and then another webinar focusing on life after stroke. And we'll have probably 2-3 experts join us, and you will all be able to listen to them and ask any questions that you may have as well. So next question comes from Janelle. Mother had a stroke at 90 years of age. What are my possibilities of getting a stroke in my 80s?
Well, we know that stroke risk increases with age in general, regardless of the family history. There's a small correlation with your family history and risk of stroke. But the most important thing for you to do is identify or know your vascular risk factors and work on treating them as much as possible. So that would be identifying any high blood pressure, high cholesterol, diabetes, heart disease, tobacco use, obesity, and physical activity. If you can recognize all of those and work on controlling them as much as possible, you will lower your stroke risk when you are in your 80s and older.
So obviously, blood pressure control is very important too, correct?
Yes.
Okay, great.
Blood pressure control is critical, and this is for both ischemic strokes and hemorrhagic strokes. The most important thing is blood pressure control. And I think we've talked a lot about 140/90 as that's kind of the threshold where we diagnose hypertension or high blood pressure. But really in stroke, we've been trying to get patients to get their blood pressure as normal as possible. And we consider normal blood pressure 120/80.
Great, thank you. Next question is from Maria. If you have a low platelet count, can you have a stroke?
Yes, you can. So it depends on how low the platelet count is. Very low platelet counts can cause the platelet stickiness to not work properly, and that can actually cause a stroke. We usually have patients see a hematologist about this and address why the platelets are low.
Great, thank you. This comes from Bambi, no question, but she just wanted to express that she was very grateful for the treatment her husband received for a stroke in January at UH Geauga Medical Center. So Bambi, we're very happy that your husband's doing well. Thank you for sharing that with us. Next question is from Carolyn. Can you tell the difference between a stroke and a heart attack?
Yes. So a heart attack is, it's involving a vessel in the heart. And so it's diagnosed using an EKG, which are the stickers they put across the heart and looking at the electrical conduction system. The typical symptoms are chest pain, difficulty breathing, sweating, pain going up into the jaw and down the left arm. A stroke actually has a couple of different reasons why it occurs, but usually is due to a blood clot that goes to the brain or a blockage in the brain. And so the symptoms are different. Now, it is sometimes difficult to know if the pain and numbness in the left arm is stroke or heart attack, but it's quickly differentiated by the use of an EKG and blood work.
Great. So another question in that vein is, so when the EMS unit arrives at location or when the patient gets to the hospital, can they tell right away that a person's had a stroke?
Well, it can be a little bit difficult because there are many conditions that can mimic a stroke. But usually we can have a suspicion right away that this is fitting a stroke syndrome. So based on where the blockage in the brain is occurring, we know the brain on the right side controls the left side of the body. And so based on the symptoms the patients are having, if it fits with what we know for stroke syndromes, we can make an educated guess that that is most likely what's happening. But we have to admit patients to the hospital and usually get an MRI to help confirm the diagnosis and rule out any stroke mimics.
Great, thank you. So we still have a little time left. If anyone else has any questions, don't be shy. We're here to answer them for you. Again, just want to remind everyone that May 2021 is Stroke Awareness Month, so we'll be putting on several more events. A couple reminders for the audience as well. As registrants and attendees of tonight's event, you will be receiving an email that has a link to this evening's presentation in it. So look out for that in the next couple of weeks. We do have another question. Does a person with right branch bundle block a candidate for a stroke at some point?
So right branch, the bundle blocks in general are not considered classic stroke risk factors. But I would usually recommend that you see a cardiologist or an electrophysiologist and make sure that there's not another cardiac arrhythmia that would put you at risk for stroke. The most common cardiac arrhythmia that puts patients at risk for stroke is called atrial fibrillation. And that's not related to a right bundle branch block, but it is a common benign arrhythmia that patients get with, that we recognize in patients as they get older. And this can be a precursor, be associated with stroke. Atrial fibrillation causes the upper chamber of the heart to quiver. Little blood clots can form and break off and go to the brain. So it's important to know if you have them.
Great. We have another question from Mukund. Are there more benefits from using aspirin than not?
Well, so this has been in much debate in the most recent years. If you have vascular risk factors and you have any history of cardiac disease, peripheral vascular disease, or stroke, there are definitely benefits to taking an aspirin every day. We used to recommend aspirin for what we call primary prevention, meaning in patients who've never had a heart event or stroke. But recent population health data has showed that that is not necessary or indicated. So many of the primary care doctors are now recommending that patients don't take an aspirin regularly. There are some bleeding risks to being on an aspirin every day with upsetting the stomach and developing ulcers. So I encourage you to talk to your doctor about whether or not an aspirin would be indicated for you.
Thank you. Another question. This person fell in June, had a concussion, and was told that another fall with a concussion would probably cause a stroke. So just basically a statement, but looking for some feedback from you.
Okay. So concussion falls in the category of concussion and going through kind of the traumatic brain injury side. In a really severe head injury, you can get something called like a bruise on the brain or a contusion, but it is not in definition of itself a stroke because it's not related to a blood vessel that's blocked or bleeding. We're most concerned with concussions leading to memory loss and headaches and post-concussion type syndrome. It is important that you don't get another concussion going forward. There's one in maybe what they're getting at is that in older patients, when you fall and hit your head, the veins that are draining the brain on the lining of the brain, those get kind of disrupted and they can ooze and cause a different type of bleeding in the brain called a subdural hemorrhage. So that might be what they're referring to. It's a little bit different than the strokes we're talking about today.
Great. This is a great question. Does a person always collapse when they have a stroke, or will they be able to call for help?
Oh, so a person would only collapse if it's because of the weakness or the paralysis that they're suffering because of the stroke. Stroke has lots of different symptoms. Some people just have slurred speech. Some people just have a facial droop. Some have difficulty speaking. Others just have numbness on one side of the body. So it depends on the area of the brain that is affected. And that will be what the type of symptoms each patient has. Most patients are able to call for help. Some patients are not. And what we find is that family members are able to kind of check on different loved ones. And if they don't hear from them, you can actually do a wellness check either by yourself stopping over their place or calling the local police or EMS and having a wellness check if you're not hearing from somebody that you expect to hear from who's elderly. That's how we're able to kind of really identify patients who were unable to notify us of a stroke. But the vast majority of the time, patients are aware enough to be able to alert either a family member or call 911.
Great. This question comes from Josh. Can you get tested for a clot or aneurysm if you use tobacco or have other risk factors?
So we don't typically screen patients for brain aneurysms, and that's because they are quite rare. And the likelihood of having one big enough that will rupture and bleed is rare. The time in which we do screen for aneurysms is in certain patients who present with neurologic symptoms, and they would see a neurologist and discuss their symptoms to see if that would warrant a brain scan. And in patients who have had 2 or more first-degree relatives who've had a brain aneurysm. And we define a first-degree relative as a sibling, a parent, or a child, because there are a very rare number of people who have a genetic condition that causes aneurysms.
Great. Well, that looks like all the questions we have for this evening. And it looks like we have a few more questions. So that's what I need to do to get more questions to come in. So this next question comes from Stephanie. My dad had 4 strokes 3 years ago and has had a baclofen pump placed. it seems to me that it has actually made his leg swollen and really tight. And that's it. There may be something missing, but.
Okay. That is actually.
And she also added, I'm sorry to interrupt you, she also added that it seems to have made his walking worse.
Okay. So that's something I would have you discuss with your father's physician. Baclofen pumps are used to help with spasticity or stiffness after a stroke. But I'm not knowing your father. I think I would have him talk to his physician or the person who placed the baclofen pump.
Thank you. This question comes from Carolyn. Can you have a stroke without any signs?
Yes, you can actually have a silent stroke, and we sometimes see this when we do brain scans. We pick up old silent strokes that patients have had. This is because the area of the brain that was damaged is an area that didn't cause the patient any clinical symptoms. Oftentimes we see this actually in the back of the brain in the cerebellum. The cerebellum controls your coordination and balance, and really is a large, most of it is kind of unused by all of us. And so small strokes can be there without really affecting balance or people being aware of, but we do see them on the CAT scans or MRIs.
Great, thank you. That looks like it is it for the questions.
Okay.
Again, Dr. Opaskar, thank you so much for your time this evening and sharing all this information. And to our participants, thank you for joining us and all the important questions that you asked. We really appreciate you coming out this evening and joining us. Again, if you'd like to make an appointment with Dr. Opaskar, you can call 440-772-0050. And as Dr. Opaskar mentioned, we have providers all across Northeast Ohio. If you're not on the west side, we have providers that are close to your home, and you can reach them by calling 216-799-0467. And if you are looking to find more information out about stroke, our website is a fantastic website full of information. You can visit uhhospitals.org/stroke. So again, thank you all for attending this evening. We will send you an email that has a link to this presentation should you like to watch it again. And again, we just want to thank you all for joining. Have a great evening. Thank you.